Good morning friends, today I will discuss about the pituitary tumors, their anatomy, physiology, pathology and the treatment for the pituitary tumors. The pituitary glands weight around 0.6 gram. It is composed of anterior adenohypophyseal component in a position with a morphologically, embryologically and functionally distinct posterior neurohypophyseal component. This is the two part of pituitary gland, adenohypophysis and the posterior pituitary hypophysis. Embryology, entirely endoectodermal in origin. Adenohypophysis develops from Rathke's pouch by the upward invagination. And the neurohypophysis develops from the infundibulum, downward extension of floor of diencephalon. Endocrinology, anterior portion, it secretes multiple hormones like FSH, follicle stimulating hormones, luteinizing hormone, adrenocorticotropic hormone, thyroid stimulating hormone, prolactin and growth hormone. The FSH is clinically silent. ACTH is hypersecretions causes Cushing disease, moon phases, buffalo hump, purple striae and hypertension. The TSH causes goiter, moist skin, tachycardia, palpitation and insomnia. Prolactin causes hyperprolactinemia, causes menstrual irregularities, infertility, galactorrhea and weight gain. Growth hormone excess causes acromegaly, overgrowth, carpal tunnel syndrome and hyperhidrosis. The posterior gland neurohypophysis secretes two hormones, oxytocin and ADH. Oxytocin causes uterine contractions and lactation. ADH causes SIADH, increased water resorption and low sodium. And the axis causes DI, where increased urination and high sodium. Epidemiology, pituitary tumor accounts for 10 to 15% of all primary brain tumors. The highest incidence between third and sixth decade of life. It is more common in women. Genetic predisposition seen only in MEN1, although this accounts for only 3% of pituitary tumors. The cellular masses, the pituitary stay in cella. The tumors which found in the cellular area are adenohypophyseal origin, pituitary adenoma, it is micro or macro, pituitary carcinoma, granule cell tumor. Non-pituitary origins are meningioma, glioma, craniopharyngioma, germ cell tumors. Some other cysts and hematomas like epidermoid, arachnoid cyst, Rathke's cleft cyst, dermoid, hypothalamic hematoma, metastatic lesions, inflammatory lesions like sarcoidosis, Langerhans cells histiocytosis, lymphocytic hypophysitis, vascular lesions like aneurysms and cavernoma. Pituitary adenoma is classified by endocrine, clinical appearance, pathology and in bioimaging. Adenoma, prolactinoma is most common. 30% of pituitary adenomas present as amenorrhea with galactorrhea. The prolactin levels are usually more than 200 nanograms per ml. The first line treatment is pharmacological. Dopamine agonist like bromocriptine is given. The growth hormone secreting tumors are most commonly macroadenoma, occur in 4th and 5th decade of life. Common features are like coarse facial features, thickening of lip, enlargement of nose. GH levels are usually more than 5 nanograms per ml. The treatment is surgery. ACTH secreting adenomas are 8 to 10% of pituitary tumors, causes Cushing disease, hypercortisolemia, state generated in a response to ACTH secreting pituitary tumor, causes weight gain, truncal obesity and buffalo hump. The free cortisol level, there is no cortical suppression on low dose dexamethasone testing and the cortical suppression on high dose dexamethasone testing and moderately elevated ACTH level. Surgery is the only option. Thyrotropes adenomas, less than 1% of pituitary adenomas manifest with sign of hyperthyroidism, high TSH and high free T4, surgery is the option. Clinically silent, 1/4 of pituitary tumors, surgery is the option. The presenting signs and symptoms, pituitary hyperfunction or pituitary insufficiency, or they can cause mass effect if it is macroadenoma. Mass effect causes headache, that is due to pressure of V1 part of the diaphragma sella, loss of vision due to compression of optic chiasm, hydrocephalus due to compression of third ventricle, and hypothalamic abnormalities causes sleep, alertness or emotion liabilities. In the imaging, MRI brain with or without contrast is to be done, including thin cuts through primary or sella. The tumor usually enhances less than the gland. labs, prolactin, FSH, LH, GH, ACTH, testosterone, growth hormone and cortisol is to be done. Visual field, optometry is to be done, causes bitemporal anopias. After 5 months there is total bitemporal blindness. MRI usually can see the cellular and supracellular tumors reaching more in the right side of the brain, causing obstruction at the third ventricle and the lateral ventricle level, causing minimal hydrocephalus. The sagittal cut, cellular and paracellular tumor involving the clavus part also. The surgical indication is when there is progressive mass effect and the worsening of vision, failure of pharmacological treatment for prolactinomas and for Cushing disease, and this failure of radiation therapy. The third is pituitary apoplexy, the abrupt or occasionally catastrophic acute hemorrhage infarction of a pituitary adenoma. It presents with acute headaches, meningismus, visual impairment, ophthalmoplegia and alteration in consciousness. Glucocorticoid replacement is the most important first step due to adrenal insufficiency, followed by urgent surgical decompression. A CT scan of pituitary apoplexy where you can see blood in the cellular region with blood in the ventricles. Surgical approaches are transsphenoidal, transcranial, transsphenoidal like endoscopic, endonasal, sublabial, transeptal, transcranial like subfrontal and terminal. The operating room for the transsphenoidal surgery by endoscope. Patient is squared to room walls. The intensifier is squared to walls and the nasal dorsum is parallel to floor. Surgeon is standing on the right side of the patient and the assistant just above the surgeon and the scrubness just behind the surgeon. These are various approaches: transsphenoidal, endonasal and sublabial. Transsphenoidal, sublabial, transsphenoidal reaching up to the sella. Transcranial, terminal approach where the terminal craniotomy is to be done, and by reflecting the frontal lobe you can reach to the cellular and pituitary area. Transcranial, 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 transcranial. You can see the optic nerve and the carotid artery. By making a corridor between the opticocarotid races, you can reach to the cellular area and the pituitary area. The postoperative complications, diabetes insipidus, there is the excessive secretion of water and the retention of sodium causes high sodium levels. We have to follow urine output and sodium levels every 6 hourly or 12 hourly. CSF leak, check for rhinorrhea, hemorrhage or apoplexy, where the worsening of vision can happen. Thank you.